And welcome everyone to our second webinar of our series Conversations on COVID-19. For those who are joining us for the first time, I'm Hala Ali, the coordinator of Easter Alliance for Global Health Partnerships and Easter Ireland. This webinar will be recorded and we will post it later on our website, www.globalhealth.ie and www.easter.eu. The slide, please, so can people see it, the website. And also we will post this in our social media as well. And now live streaming is available in our Facebook page. If you have any questions during the webinar, please raise your hand using the feature that is in the bottom of your screen. And we will back to you later when we open the floor for the questions. If you have any questions during the webinar, also you can use the questions and answers feature in the bottom of the screen. And just to know our audience better, we need to know where are you watching us from. So if you just can at this moment using the chat box and send us your location, that would be really great. Can you please? Okay. And as most of you already know, this Conversations on COVID-19 is a weekly webinar series, and it's taking place on Fridays at 1 p.m. GMT time. And it is a place for people working in global health and healthcare, where we exchange informations, ideas, experiences regarding COVID-19 with the experts in the field. We encourage you to suggest the topics that you would like us to discuss, and also send us your pressing questions, and we will try to our best to come up with answers either on the coming webinars or on our web pages. Today, the experts will discuss donor and funding challenges in the time of COVID-19, and then they will discuss hospital readiness in the European Union and worldwide. Now I will leave you with my co-host Nadine Ferris-France, the Executive Director of Irish Global Health Network, who will then introduce the speakers and lead the panel discussions. Nadine?
Great, thanks Hala, and welcome everybody from, I can see South Africa, from India, from Ireland, from all sorts of countries around the world. So today we have Ruairi Brugha, who's accompanied by his son Louis there. Ruairi is a medical doctor, a public health specialist and Professor Emeritus, a former head of the Department of Public Health and Epidemiology at the Royal College of Surgeons in Ireland. And Ruairi is going to be the webinar anchor for us, so every week Ruairi will be here at the beginning of each one. And we're delighted to welcome Nelly Comon. She's a French citizen. Bienvenue, Nelly. She joined the Global Fund in 2009 as a Senior Donor Relations Officer, and she's the manager, at the moment, she's the manager of the Donor Relations Department in the Global Fund since 2015. So welcome. We also have Una Rose Hogan, who is working with WHO as a consultant and specifically working on, at the moment, on COVID-19 and hospital readiness. So we're delighted to have you with us as well, Una. So welcome everybody. Unfortunately, Erica Placella was supposed to be with us here she's the deputy head of the Swiss Development Cooperation, and she got called into an urgent meeting to discuss issues around COVID and funding. So we're delighted that she's doing that. I'm sorry she can't be with us. Just a reminder to everybody, please do send your questions into the Q&A, and we'll do our best to try and direct them to the panel, answer them if we can, or answer them afterwards. So please keep the questions coming. The way this webinar works is, as participants, you are not able to speak at the moment, but you're able to write your questions in and raise your hands. So brilliant. So let's kick off. Ruairi, if we can, with you, if you can just kind of bring us up to date. Where are we at in terms of the context, the current situation, and what do we look like?
Thanks, Nadine. So what I want to do is to give an overview globally, some very good resources from WHO. So one of the things I want to do is just to put those resources out there. Many of you know, probably all of them by now, just to have them in one place. We looked then at some of what we covered last week about the epidemic curve and the control measures. Thanks, Ellen. And look at how we're doing in Ireland what's really happening or about to happen in the partner countries, and focus again on some of the responses that we should be considering in the partner countries that we kind of talked to in the discussion last week. I'm trying to capture it in the slides today. So, Helen, next slide. So, yeah, this slide here now. Let me just move the pictures out of the way. These are the two sites I find most useful, particularly the WHO one. And I'm going to ask Ellen just to go into the second link there, in the Gov one. We go back to the WHO one. There we are. Many of you know that, but it's just you have it there as a link that'll, if you go back to the slides later, it'll give you whatever is the update for the day. And we can see 466,000 cases, 21,000 deaths, 199 countries. We see it there on the left. The main thing in this sort of gapminder slide is to look at where the epicenters are. And even when we look at the numbers on the right, I think it has Italy, if we go up to the top there, Italy above the US, but I think actually in the last 48 hours, the US may well have passed out Italy for numbers of cases. So we see the epicenter is switched from China over to Europe and now is shifting over to the US. But Ellen, if you can kind of focus down and expand Africa there a bit in the middle, just to get, brilliant. So now that's great. That's enough now. So we see what are the numbers reporting, and South Africa at the bottom there, 927. In North Africa, above the Sahara Desert, we're seeing significant numbers, but largely there is very little reporting going on. And I think this may be leading, or could be leading to a complacency, that Africa is not being affected, when in fact what we're seeing is the massive underreporting, an inability to test at any great capacity. And we'll look later to see what are the implications of that. So back to the slide, if we can get back to it. Great, and go down to the Department of Health one next. And many of you will be familiar with this. I find the statistics are becoming a lot more easily accessed. So if we just go down there and hit read more, this is what's capturing a number of important groups in terms of the Irish epidemic. So the previous slide would have shown, or in fact, if you just shift down a little bit, you'll see this is an analysis based on 2 days ago, and it had 10 deaths, but we're up to 19 deaths now. And if you look at if we go down through the categories, if you just go up to the top again, what I think we should be particularly concerned about is the characteristics of the epidemic, where the numbers are not always that meaningful. We're probably only capturing at best 10% of the infections are going to be captured in our testing. In China, by the end of the epidemic, they were getting up to perhaps 50% of cases were being detected. So the numbers don't tell the real story. If you look at hospital statistics there, so this is based on 2 days ago now, and this has changed, but we're seeing, if we go back a week, I think there was only 4 or 6 cases admitted to ICU. The really worrying one then is the healthcare workers, and we can just shift down the clusters and the healthcare workers. So how COVID is spreading. We got the healthcare workers there, who are largely, go back up, just stop there. So the healthcare workers are contracting this really for the most part through their work, and this is a particular worry. It's no longer travel related. If you just go up a little bit there, now if you stop there, what's worrying is the community transmission, and far more of the cases are through community transmission than through contact tracing. Now, it was said, I think Tony Hoolan said, well, it's good, we're not capturing that many through contact tracing, suggesting that the contacts are actually self-isolating. But what's worrying is that these are sort of endogenous community cases or clusters of cases that are just erupting around the country, a lot of it in Dublin, which suggests that whatever the containment measures and the social isolation that we've been doing hadn't taken hold at this point. Maybe just go down to the bottom and see, is there, what else? So cases by county, we won't really pay attention to that. No. Let's get back out of that now and just look at the next slide. So this was the epidemic curve that we showed last week, and the question, where are we on the curve? Ellen, I would say if you put the cursor over, or am I controlling the cursor? You over here to the left, we're still low down. Yeah, low down. We're probably down somewhere around there, a bit lower. And as to our trajectory, we may be somewhere between that very steep curve and the flattened curve. We won't know until really as we look back at the epidemic in a 2 or 3 months' time where exactly we were. But there are some signs that we're hitting that serrated dotted line. We may not be there yet, and that's the capacity of the healthcare system to manage. Let's go on to the next slide. It's another one we showed last week. I think it's worth showing again because it just shows what's the combination of measures that we are using, and it's the combination that counts. So if you look at the blue line at the bottom, the blue curve, that's the lowest curve for an epidemic, and it's based on a combination of individual measures, case isolation, home quarantine for contacts of cases, plus a range of more population measures. Social distancing for 70-year-olds, but social distancing for all of us, and the closures of schools and universities. And in Ireland, we have introduced these in a sort of a graded way, which I think most people reckon is the right approach. Whereas in Britain, they kind of they stayed in first gear and shifted up into fourth gear. So I think it does bring the community, the populace with you. Next slide. I just put this slide in just to illustrate something that we're likely to see. If we do manage to control the epidemic through these containment measures and the individual measures, we are likely to see some curves down the road. And China is now looking at a situation where they see the risk of a second epidemic down the road. We're in this for the long haul until we have a vaccine or some effective treatments that can be rolled out on a very large scale to those most at risk. Next slide. So how are we doing in Ireland? There are some links here that we're not going to go into. I just want to focus on kind of a summary, my interpretation of it. We've moved from containment phase to delay phase. We have revised our testing pathways 2 days ago. And the question was asked of me yesterday, what can we learn from these daily reports? Well, the upward trends represent 3 things. They represent that there are more cases out in the community, but it's also as we start to do more tests over the next 1 to 2 weeks, as we hit some of that backlog, and we know some of the backlog isn't going to be tested, and as we become more efficient with our testing and the time frame from detection of a case to ordering the test to getting the result back, as that becomes narrower, more test positives will come out, and the more specific criteria for testing. And that's why I say the pattern of cases is as important as the numbers. So looking at hospitalization numbers, looking at the numbers in ICU beds, looking at the number of clusters. Over the last 48 hours, clusters went from, I think, around 45, 44, up to 64. So I wouldn't be optimistic about where things are at the moment. the other thing to note is that we have a long lag phase from the onset of symptoms to when they're reported. So what we're seeing in these reports is reflecting what was happening 2 to 3 weeks ago. And what we're seeing in these reports now are reflecting the social distancing measures that were put in place 2 to 3 weeks ago. So what we're seeing is not positive, but if we are doing the social distancing well, then we have good reason to think that things may be improving, but we're not seeing it yet. Asterisks now, these are the two really big worrying points. Some of you may have heard, as I heard on the radio last night in 5 and 6, I think was a drive time, reports of the shortages of PPE in the hospitals and the stress being experienced by doctors and nurses, other health workers. And we're going to see a competition globally from the US and Britain. If we don't get this right, a lot of the progress we've made, we're going to see it really undermined by the health system just being you know, the effect on health workers will be just intolerable. Mm-hmm. The other thing that came out yesterday or 2 days ago from the ECDC is probably we knew we have the lowest ICU bed capacity in Europe. So that's where the biggest threat to us is. I might come back and say something if anybody would like to discuss about vulnerable groups and migrants. I just got an update by phone an hour ago from the national lead. It is really worrying, and maybe we could deal with that in question time, because otherwise I'll be talking too much. Let's just move on.
Thank you, Rory. And I see there is already somebody asking about, really concerned about overcrowding in direct provision centres, exactly what you're talking to.
So let's come back to that one.
Come back to that. And just to clarify, Rory, in terms of the curve that you presented, that was the specific response for Ireland, isn't that correct?
It was, but it was more of a theoretical curve. It was one produced by the Department of Health just to show this is what we're trying to do, the flattening of the curve. It wasn't, but modelling work has been done in Ireland. There's a team who work quite closely with Imperial College in London and London School of Hygiene, and the initial model, the model has actually fitted well, or the cases in the initial phase have fitted well with the model. So we can trust the models as far as we can see.
Okay, good, Rory. Thank you for that. Thank you for kind of bringing it all together. And I think one of the things you said early on is, the reason we're not looking at graphs and curves at the moment, for instance, in countries in low middle income countries, is because a lot of the testing is just not happening and not possible. And I think, that's obviously there's many reasons for that. But I'd like to come to Nelly, if that's okay. Nelly's working with the Global Fund to fight AIDS, TB, and malaria, and most of us know that the Global Fund, it's a brilliant organization that mobilizes and invests more than $4 billion US per year, and supports partners in countries in over 100 countries. And Nelly, I know that all of you have been working around the clock with the funding mechanisms already there for countries. Can you tell us a little bit about what you decided to do from the Global Fund in terms of how to respond to countries who are thinking ahead in terms of what they're going to need to do?
Thanks a lot, Nadine. Yeah, thanks. Just to put back here, effectively, the Global Fund into the context, we are primarily fighting AIDS, tuberculosis, and malaria, while supporting health system strengthening in approximately 140 countries as of now. But obviously, we have a major responsibility as well as an actor in the global health landscape and in development. So that's really why we have encourage the countries we're already supporting over the past weeks to really express their needs and take into considerations the WHO guidance to take actions to fight against the COVID and the virus. So we have put in place operational guidelines for all the countries we are supporting over the past 3 weeks, and we are acting as fast as we can with decisions taken over 3 to 4 days. And we are authorizing basically the countries that we are supporting to use the funds that have already been allocated and savings that they have identified to reprogram all of them towards activities that will help them fighting the COVID. So it includes activities such as what we call the emergency preparedness, the surveillance, equipment. I could see for Ireland that staff are lacking PPE. It's a big concern as well in African countries. So we are trying to help them preparing for that and asking for or ordering for PPEs, but also helping the laboratories to help testing for sample transportation, and also to put forward some information campaigns. So those are the kind of activities that countries are now authorized to ask funding for within the grants that are already existing. And we are also working quite a lot with our partners, especially the US and China, but also with the WHO and the others on the supply chains issues and challenges we have not faced yet, but we are expecting to face somehow at some point. For the time being, we are okay. We estimate the impact of the COVID for the time being as low to moderate for all the product supply. We were facing some issues around what we call the API, which are the active pharma ingredients, because they were mostly produced in China, but China has resumed its production. So we are now working with them for the shipments and the logistic arrangements to be able to try as much as we can to help countries to avoid any disruptions in treatment and services for the countries. In addition to that, obviously, it goes beyond the countries, but we are working internationally, especially with WHO, but also with Gavi, with UNITED, and with all the partners within the Global Health Action Plan. But beyond that, to see how we can work effectively together and coordinate better our actions around supporting the countries. I think I will stop there. I mean, it's moving very fast for us. As of today, we have 24 countries that have asked to reprogram some of their fundings for activities towards the COVID. It's equivalent to approximately $20 million. I know that today it will be probably an additional $5 million that will be approved. So it's going fast. I mean, Monday it was 14 countries. Today it's 24 countries. So you can see that we have put together a system internally that is trying to help the countries as much as we can and putting not too much pressure, but helping them in the processes.
Mm-hmm. Yeah, thank you, Nelly. And I see that Gavi released something there early this week to say that they've also started to make their funding available now to low middle income countries to be able to respond. Do you have any advice for all the donors who are together at the moment trying to make decisions about bilateral donors and others who are trying to make decisions about how to get funding, how to release funding, how to be flexible? I mean, what have you learned already? And I really appreciate that this is so new and you're learning day by day. So anything you could share, I think, would be useful.
Yeah, we're discussing a lot with donors, but we are also discussing a lot with our partners to try to coordinate all of our efforts. So for us also, we are going to look, and it might change next week. Our governance is really looking at how we can help also donors, facilitating some of the channeling of their funding towards COVID through the global funds. I think we have all in mind that it might be important not to create too many funds and use what is already existing in the global health landscape. And this is the discussion that is taking place both with WHO, but also with our donors. So that's what I would say. It's a concern for all of us that we should not disseminate our efforts, but rather than trying to gather and coordinate as much as we can.
Mm-hmm. Yeah, and I see, Nelly, a question just come in there in terms of, is the Global Fund able to support in terms of water sanitation? At this point, is the funding able to be reprogrammed to support WASH and other things in healthcare facilities?
So there's probably, I don't know exactly the details of the activities that we can plan, but definitely all the measures that are for fighting the infections and the control of the infections within the health clinics are something that we are supporting. Mm-hmm. Mm-hmm. So it's mostly gloves and protections for personal equipment, but there are other measures as well.
Mm-hmm. And I suppose, again, probably too early to tell, but in terms of civil society, just imagining that civil society are obviously extremely important at this time in the countries in terms of reaching people with these different different issues or like items like social distancing that need to happen, and presuming that civil society are part of those discussions and accessing those funds as well.
Definitely. I mean, the basic principles of the Global Fund is that everyone has a voice, and the CCM, what we call the CCM, which is the country coordinating mechanism, is the primary channel to ask for reprogramming as well. So it's a system that is going on in the countries whereby Basically, the entity that receives our funding is the primary requester, but it has to go and consult with the broader platform, which is called the coordination mechanism. We are obviously very concerned about the communities and the most vulnerable, so we want to ensure that those have a voice to the response, but also are protecting themselves, because they will have a major work in the community to protect people and access people.
Right, yeah. And thank you, Nelly. And it's wonderful that the systems are in place. I think at this time, you know, we talk a lot about health systems, but I think with Global Fund and Gavi and others, having those kind of systems in place is really important for funding. So thank you for that. I think, you know, I've heard a lot about PPE and being prepared in health settings. And I wonder if I could come to you, Una Rose, and just, you know, you're obviously, you know, working intensively at the moment in terms of WHO and how it's supporting governments to support hospitals to be prepared. What are the elements of hospital preparedness that WHO is kind of really looking at this point? And you might just talk, as you speak, Una Rose, you might speak about, say, Ireland and Europe, and then just touch on whatever it is you know, and you can share with us about the low middle income countries as well.
Yeah, sure. Thanks, Nadine. So I suppose really, you know, when you think of hospitals in terms of preparedness or readiness, you know, you have to think of the hospital organizationally. They're really complex. So actually what we've done at WHO is we have revised, you know, a formerly existing checklist that was there for pandemic influenza for H1N1. And we have been supporting, say, a range of countries, actually going to the countries, conducting assessments around these components. And it might be really helpful, actually, Ellen, if you can pull up the slide so I can give people a visualization in terms of what I mean for these components. So broadly, there's 11 categories really that we look at, and it's not that we need to review all of them because I know our time is short, but you can see here in the very first instance we have what we call the IMS, the Incident Management System. And for those of you who work in the humanitarian area, you will know this. You know, you call it an emergency operations room, a control room, whatever you want. But essentially, these are going to be the brain, the people who are responsible for all the different components of readiness. One of the most important things, which is actually related to what Rory said earlier, it's become very important for COVID to actually have prospective replacements for each of these components for hospital readiness, because what we've seen is so many healthcare workers are becoming infected themselves that it's really not sufficient just to have one person responsible anymore. Because we don't have the time to go through all 11 components, if you see these three areas that Ellen has just popped up on screen for there, these kind of three pillars, you can kind of group hospital readiness in terms of these, and the first really is in relation to administrative readiness. And here we're thinking about things like, you know, surge capacity, you know, can you mobilize extra human resources and equipment? Is there effective communication systems in places? And that means not only within the hospital but also externally, you know, in terms of how do you communicate with the National Reference Laboratory, for example, or the Ministries of Health? Do you have the kind of human resources that you need? Ellen, you can pop up actually the next three animations as well if you like. Thank you. In terms of clinical readiness here, really what we're thinking of is continuation of essential services. You know, what happens to your existing patients? Where are they going to go? You know, do you continue to provide some of the services you already provide, or do you become a fully dedicated COVID-19 facility? That's happening in many, many countries. You know, when we think of infection control, that probably requires more time to discuss, but hopefully we'll get an opportunity to discuss that later in this webinar. Case management also falls under clinical readiness. Do you have a trachea? You know, what about critical patients? Is there oxygen availability in the hospital? It's far beyond just infrastructural issues, but these are some of the types of things you need to work through with hospital managers, you know, and ministries of health as we try to find kind of like either dedicated facilities for COVID or, you know, ensure that they're prepared. Similarly, surveillance falls under this clinical readiness section. And here we really kind of think about, is there somebody who can be on top of the changing case definitions for COVID, for people who meet the criteria for testing? Is there some method for kind of early warning systems? I think all clinicians at this point have a really high level of clinical suspicion anyways for COVID, but it's another component to be aware of. And finally then the support service readiness, which is that bottom you know, button or barrier there at the bottom of the slide. Here we're thinking about all the maybe not directly clinical services, things like pharmaceuticals, supplies, the unsung heroes of the hospitals, the cleaners, the laundry, the security, the kitchen staff. You know, what is their role? How can they be protected? How can we, you know, surge up their capacity if necessary, or what people can we reduce from being within the hospital grounds? Similarly, the laboratory has a very important role. And for those of us who work in low-income countries, frequently the lab in the hospital is not the one who's going to process the COVID samples, but their role is more in terms of handling up to national reference labs. So look, this is just a really shallow overview, but it's just to kind of give you a perspective. So we've been working with hospitals, going through each of these in really great detail. Of course, we couldn't have imagined the speed with which this would escalate. Sorry, go ahead.
No, but you just mentioned infection control, and I just wonder if you could say a little bit about what are the main barriers to being able to really to do this properly. And again, you know, I would say, like, you know, in Europe, you could just, you know, what are the barriers in Europe, and what are the barriers in low middle income countries that already we know?
Look, you know, there's so many barriers to doing appropriate infection control practice, say, in relation to COVID. I mean, we have our very obvious barriers. You know, we're all working within a severely constrained PPE supply, you know, globally. That's understood. We also have infrastructural concerns. Pretty much most hospitals have an inadequate amount of isolation facilities and even cohort facilities as well, particularly in low-income countries. But we see that here as well, you know, in Europe. It's relevant right across the board. You know, that said, I think the human behavior side of infection control is infinitely more complex and harder to address. You know, if we think of healthcare worker behavior here, we're seeing such high rates of healthcare workers, you know, becoming infected themselves. Now, this isn't necessarily to do with their lapses in infection control practice. This can simply be because of the virulence of actually coronavirus itself. But we're really starting to suffer from the systemic, you know, and lack of underfunding and deprioritization of infection control, you know, under normal circumstances. And by that, I mean infection control is generally not integrated well into hospitals in low middle income countries. It's rarely a specialization, actually. And if it is, it's generally not that desirable of a specialization. Frequent hospitals might have something like a hospital epidemiologist doing retrospective surveillance, but there's often little engagement with the clinical infection control side of things. I would say there's inadequate infection control education right the way from undergraduate level through to, you know, continuing professional development levels in a majority of low middle income countries, for sure. There's often, you know, a total absence of like professional regulation in terms of medical and nursing licenses, and this being linked towards, you know, kind of mandatory infection control training, which we have, you know, say here in the UK and in some of the more higher income countries. But I would definitely say, because I'm conscious of time, I suppose, you know, for me, infection control, it's the great leveler in medicine. It's one of the few disciplines where everybody has a role to play, from the security, the cleaner, the admin, right the way through to, you know, your surgeon, your hospital director, and all the rest. But we need to look at these cadres of staff as well in terms of including them in formal infection control structures, which we don't do. And one final barrier, and this is very relevant for low middle income countries, those of us who work in those areas, we know that family members actually are generally stay on site with a patient throughout the duration of their hospital admission. They sleep in the hospital, they sleep under the bed, they sleep outside, they cook for the patient, they clean the patient, they bring them to the bathroom, they do a whole range of patient advocacy and what we would consider traditionally nursing roles. So what's going to happen as we see the epidemic expand, say, in sub-Saharan Africa? You know, there isn't the human resources for health to actually fill those roles. So will family members continue to care for COVID patients? I think probably not, but then what happens? You know, who fills that gap? So go ahead, Nadine, sorry.
This is just like a drop in the ocean in terms of some of the challenges that I'm sure our partners and our friends are at the moment just trying to deal with, as we are here in many similar ways. I just wonder, you know, the issue of PPE has been coming up a lot, you know, and I think it would be really interesting to know, I mean, how, for instance, Nelly, and maybe for Ruairi as well, you know, how can donors be more effective in making sure that PPE is going to be available for low middle income countries when, you know, we're hearing that the high income countries are placing big demands on the supply at the moment. You know, any thoughts on that, Nelly?
Yeah, it's quite difficult to respond. I mean, I'm not the expert of supply chain, but that's really what we're looking at as well. I mean, what is available on the market, and try as much as we can to have a good picture of what is available and be able to order those PPE whenever they are available for the countries that have asked.
Mm-hmm. Yeah. And maybe Ruairi, just coming back to yourself, you might say something on PPE and then maybe something a little bit around the vulnerable groups and maybe, you know, the concerns for direct provision here in Ireland for people in direct provision. And just to remind everybody who's with us today, please ask your questions in the Q&A and I will do my best to pick them up and direct them to the panelists. So please, you know, just go ahead and put your questions in there, or even comments and thoughts like you're doing there. Yeah, Ruairi, thanks.
I'd actually like to focus on Rachel's question. I mean, it touches on that, but I think she's touched on the issue of what are the indirect effects from the health systems being overwhelmed. And there's a really excellent report came out from WHO just yesterday, which I've been reviewing. Ellen, could you just turn to slide 8 on my presentation there, and I'll just start talking to it while you try to pull it up there. And I'll while you're pulling up the slide, just to touch on what Nora was saying, should we test, that's the one. Should we test? Well, I don't think we will, that the poorest partner countries in Africa will ever really have the capacity to test on the scale we're doing here in Europe, not to mind the thorough scale in Asia and Southeast Asia. And I think we need to look and engage with donors around where are the priorities. And I've kind of listed them below there. PP, as we said, protect health workers. So it does need to be a priority for donors. I don't have the answer to the global competition that David Weekliam also asked about, unless we can find ways of producing these more indigenously. But rather than test, which has been the answer in China and Taiwan and elsewhere. I mean, Mike Ryan was saying the other day, a lot of the African countries have quite good surveillance systems. And I think it needs to be a much more targeted approach to try and get a good overview of the epidemic. Maintain essential health services. And this is the report that came out yesterday. The secondary effects of the COVID epidemic are potentially a lot worse than the primary effects. The primary impact may not come as much of a shock to some of the poorest countries as it's coming to Europe and North America, because it will again be the elderly and the vulnerable are the ones who will have the most serious illnesses and who will die. But the impact on the health system will disrupt the programs. Some, we have established so successfully over the last 20, 30 years, EPI, Safe Motherhood and others. And when it comes to engaging with donors, we then need to see what are the other programs that are being disrupted, such as food programs, engaging around reallocating funds to priorities, and protecting the most vulnerable, taking a much more system-wide approach on the impact on people. And at the bottom there, I just put sort of a question mark against large-scale testing and a question mark against social distancing, not because it's not a good thing to do, but we're doing it in Europe on the basis that we can actually control the epidemic, that it is feasible to socially distance. It is going to be very difficult in slums, in camps to do it. And what is it something that's going to achieve that much? And the one with the red X at the bottom is the lockdowns, which are being imposed by governments. To what purpose? Maybe somebody could explain to me, what's the purpose of India or South Africa locking down for 2 weeks or 3 weeks? Because they're not going to have the widespread testing. They're not going to have the widespread contact tracing. We're looking at a different type of epidemic. And I think we need to really see what are the priorities in that epidemic, focus on some of the areas that Una Rose was saying in terms of keeping hospitals functioning, and seeing what has to survive the epidemic, because I think COVID is going to sweep through many of our partner countries in 2 or 3 months. And what we're going to end up with is, yes, large-scale mortality, which we may not be able to avoid, and an immune population, those who have survived. But will they have the programs they need around childhood vaccinations, pregnancy services, all the basic program, antiretroviral program. We need to keep all these things going, and we need to make some hard decisions. 2 slides down, this is the report. Next slide down, this is the report that's come out. Operational guidance for maintaining essential health services during an outbreak. WHO are doing a brilliant job, UNRWA. It's a short document. The last slide is just the next one. This is what it covers. We need to bring in the epidemic coordination together with the coordination of the health services and make some decisions in these 5 areas.
Mm-hmm. Yeah, thank you, Ruairi. I wonder, Ruairi, if you could say something about, the direct provision of vulnerable populations. I see a question in there, is it too late to move asylum seekers out of direct provision centres? But maybe even just more generally in Ireland, you said you had an update recently. Could you just tell us a little bit about what's happening there? And I see somebody from the UK just interested to hear this information as well.
I think it's because what gets out, what gets reported by the NFET and others is always 3 weeks out of date. And there's also rumours going around, anecdotes. And if people who are really at the coalface, like the National Lead for Vulnerable Groups and Migrants, if you get a chance to hear from them, yeah, it's serious stress now. What's coming back to bite us in Ireland is our housing situation, that we have large numbers of people in very confined spaces. And once COVID gets in there, now some people are saying, oh, we need to kind of close down or somehow make these direct provision sites, better places where you can separate people. But what that means, discharging people into the community with COVID, and that is what has been happening. Particular ethnic groups, I was wondering, should I actually mention it? But the National Lead said it's well out there in the media. There's a real problem in the Roma community, and it's really impacted on them through one of their community workers who actually has died. Travellers, homeless, addiction services. We really need a joined up thinking around how to manage this. Mm-hmm. And the thing is, the people at the coalface are working long hours of the day. Maybe some of these things do need to be taken up at a more higher level. Is Department of Justice and Department of Health, are they really talking to each other? Are they talking to the right people on the ground? Because these are the clusters that are going to be the most difficult ones to manage. Mm-hmm.
Yeah. Thank you, Ruairi. And I see just a question in there from Emily just talking, and I'd really love to hear if there's NGOs, there's NGOs on there, just particularly even if you want to share a comment about, how are things in low middle income countries? How are you managing? How are you continuing with your current programming? And what are you finding in terms of adapting to what needs to be done for COVID? And I'm just, Emily there is asking, many charities are going to need to take a more flexible approach to be able to adapt. How can funders best support charities to do that? And maybe Nelly, just coming to you, I mean, how can donors, all types of donors, what can we do to best support the NGOs and others on the ground?
Well, it's a difficult question. Basically for us also, it's really to try to continue the business as usual as well, in addition to addressing this situation that is a very specific one. Because also it comes back to what Ruairi was saying. I mean, the COVID is a situation that is highly stressing and that we need to address, but what's next? And the next for us is also to ensure that we continue to support the civil society that we are working with for the people who are affected by HIV, by TB and malaria. So it's a fine line, but it's where we are trying to as well ourselves being supportive of the COVID, because we need to do that. And we are also trying as much as we can to continue supporting the civil society. So in the grants that we have, I mean, we have a system in the Global Fund whereby the funding that is going to a country is a dual track funding, especially for the low middle income countries. It's very important. And that dual track funding means that we're working at the same time with the authorities, but also with the civil society. And for us, it's important to continue the support that we are providing to the civil society, also in the context of the COVID. So they are the ones as well who can ask for reprogramming of fundings as well.
Mm-hmm. And then, I mean, I guess a follow-on question is, you know, from somebody there is, any tips on repurposing existing grants, you know, in terms of eligibility and audits and that kind of thing? And I know, again, it's early days, but any thoughts on that?
Yeah, no, we have operational guidance for that, so that are being developed while making it. So it's a bit difficult, and some of those have been already published in our website, but some of those are with the people in the Global Fund that are managing the grants. So the advice is really to get through the people in the countries that are managing the funds of the Global Fund, so then they can have that discussions with the people at the secretariats around the guidance and what can be reprogrammed and not reprogrammed. We are trying as much as we can to put a lot of flexibilities into our procedures to help the countries, while keeping in mind that we're receiving public funding and we need to be a little bit careful in the management of those funding as well.
Yeah, thanks. I see more questions coming in there just about, you know, everybody trying to think about what to do. And Paula there is just saying that, you know, in the field, what kind of advice should they be giving for community health volunteers in low middle income countries? You know, should they continue on doing their work? Should they stop? These you know, so many questions that the NGOs are dealing with as well. And Ruairi, I also see a question there for you. You mentioned the third epidemic. You want to pick up on that, or anything else you see there?
I'm trying to, I'm hitting send now. I'm not sending it privately. You're teaching me to come into the 21st century, Nadine, with all this technology.
Happy to do that, Ruairi. We are happy to serve.
I want to be a Luddite, have a quiet life. Yeah, I talked about it last week. The suppression approaches in China and South Korea have worked, and we've seen virtually eliminating the endogenous epidemic in China, and the only cases are the imported ones. I think in Europe and North America, in Ireland, you know, we're aiming for suppression, but I think what many European countries are seeing is much more of a mitigation response, so that the epidemic will continue, but at a more flattened level. I would want somebody to tell me, is there any realistic prospect of somehow mitigating this epidemic in the poorest countries of sub-Saharan Africa? Because I don't see it. I just don't see how we can really get all these individual measures and all these population measures working effectively. And I think if this is going to happen, if this epidemic is going to sweep through like a tsunami, and many vulnerable elderly people die from it, we have to see what is it that we can do to not only protect the health services, but to protect social cohesion, information, the social vaccine. People need to understand, we don't want a situation where health workers are getting blamed. We don't want a situation where health workers are falling ill in such numbers that they can no longer deliver their routine core services. We do really need to look and say, what are our objectives in some of these poorest countries?
Yeah, and what have we learned from other diseases that we've been working on for years, like Ebola and HIV and other things? And in fact, in 2 weeks' time, the webinar is going to focus on just that. And what have we learned, even about things like stigma, for example, and blame, and you know, some very important lessons. We don't need to be relearning all of these things as well.
Far more people died of HIV, malaria, TB in countries experienced Ebola and died of Ebola.
Right. And died of COVID, or dying.
Yeah, but in Ebola, that was the lesson, that Ebola didn't kill as many people as died from the lack of the core services that got disrupted.
Right. And just on that, you know, UNRWA, just coming back to you, you know, what advice, obviously, you know, the health system, including community health workers, which is a much bigger part of a health system in low middle income countries, you know, any thoughts on that?
So any thoughts on, say, in terms of community health workers, what to do?
Yeah.
I mean, yeah, it's really a challenge, because, I mean, even if we think of in terms of, say, you know, resources, community health workers are really right down there at the lowest level in terms of actually, you know, having PPE availability, or, you know, any of the equipment that they may need. So, I mean, I don't really have a quick answer to that. I think what you will actually find is that, you know, community health workers, we saw it during the Ebola response as well, you know, they'll have a lot of heart. They will continue to work in spite of that. But, you know, as a result, they may actually become transmitters of the infection. So, I mean, you know, I don't think there's any right solution. I think we will need our community health workers, but I do think that, yeah, we probably really need to look at ways to protect them as well, you know?
Yeah. I also saw a couple of, you know, people coming from the audience, and I heard it here as well, is just, you know, the possibility of producing locally some of the PPE equipment, because I think at that point it's going to be, you know, it's going to reduce the amount of measures that can be taken are going to reduce as we get further and further into the communities, or more and more working with the vulnerable groups. So yeah, thanks for that. Just coming back again, Rory, to you know, vulnerable groups, asylum seekers, you know, could it be a sensible period of isolation before relocating? Could that help? How can we, you know, you mentioned the Department of Justice working with the Department of Health. How can we ensure that happens? Can we?
Yeah, and I know that I didn't answer that question that I think came from Amaka. I'm not at the cold face now, and I could give an ill-informed answer. I think we do need to find ways to deconcentrate these very vulnerable people. It might require doing it along with some isolation. Certainly, if you've got a direct provision centre, and there is one that is highly vulnerable at the moment, where there are cases or suspected cases, we should be looking at where else people can be moved to, where they will be safer, and where we can reduce the risk of clusters getting much larger. I do feel that Department of Justice, who control a lot of these centres, may have a key role to play, and the other group to consider are the NGOs. We hear them in the media sometimes, and I did ask the national lead, what can people do? Because there will be people listening on this call, and getting in contact with some of these NGOs. I mean, Pavy Point was mentioned in terms of travellers, to see what do they need. There has been a little bit of a fall off of staff from some of these NGOs. People are scared. People are not reporting to work. They don't want to work in this area. You know, and for some people there are genuine reasons why you can't, because you're caring for elderly relatives. But I think that might be an area where people could just explore. NGOs, community groups often do very effective work, and I think just making sure that they are also linked in with the public health specialists who are trying to manage the response.
Yeah, thank you. Good. So just maybe I'm just going to come to each of you. Just any last comments. You know, if you want to even leave us with, I don't know, just a point or two in terms of your current thinking. You know, everybody here, I mean, there's people from all over the world on this webinar, and everyone is trying to do the best they can, trying to keep on top of the information, trying to think about what, you know, how we can all repurpose ourselves and what we're doing. Anything, any kind of words of I don't know, wisdom for us, Rory, or anything to leave us with?
I think that last week I talked about anxiety, and I think we all carry it in that sense of I'm not doing enough, or could I be doing more? And when I talk to people at the coalface, I do have that feeling. But the thought that occurred to me was that you know my lifestyle, Nadine. At 4:30 this morning was centering yourself, just finding a place within yourself to help manage a lot of what's going on outside. It is about caring. you can't care for others if you don't care for yourself.
I love that, Ruairi. And just to add, you know, I think it's also about structuring your day, and I'm starting every day with, you know, with a very, very small, slow run on the beach and a swim, and also looking at what stress or what anxiety or stress I might have, and using, you know, a method, the work of Byron Katie, to question my own thoughts, a kind of a meditative process. So I think it's really good to know that if you're trying to support, you need to support yourself first as well. Nelly, how about from your side in terms of, you know, just in terms of what you're dealing with there? What can people, how can people can we be doing more? What can we be learning? Anything from you?
Yeah, it's tough time for everyone. So from an individual perspective, really, we need to continue implementing the measures, because we all know in different countries we're reaching the peak, and we are very concerned about the African countries as well and what's going to happen to them. But on the positive side, I think it's pushing everyone, including the Global Fund and myself, to do more coordination and work together. So I really hope also that will help us getting out of that situation and continuing the business for the support of health system strengthening in the countries where they need them.
Yeah, and I'm really, you know, in this moment, we're very proud of Ireland that we're such a supporter of the Global Fund, and grateful to you for continuing your leadership as you've done just now with COVID, and watching other donors who now follow. So thank you for the work that you're doing, Nelly, and all the team. And how about Una Rose? Anything to leave us with in terms of anything specific around infection control?
Yeah, well, no, I suppose really just, I mean, kind of a more reflective in terms of what you've just been saying there. It's really, I think we're all struggling to have this really rapid shift in our mindset. You know, this is an emergency situation. It's absolutely just not business as usual. You know, by way of example, I was in Armenia last week with WHO, and I was, you know, performing kind of a surge capacity piece of work with a hospital there to see how we could, you know, scale up. And at that time, our really worst case scenario was we had imagined if we had 200 patients. That was 6 days ago. Today, there is 329 cases. We had gone from 1 to 329 in a matter of 6 days, and we're seeing this everywhere. So it's escalating at a way that we couldn't have imagined. So I suppose, you know, what I would say is just, yeah, I mean, you know, it is a time of unknown. I think we're all working, you know, far beyond our own normal surge as well. We're also having to surge ourselves. But yeah, I mean, what you're saying there in terms of self-care and all the rest, it is really crucially important. But it's, yeah, I suppose to expect that we're kind of in it for the long haul, but also to recognize that this will end too. Yeah. You know, in the midst of every epidemic, you know, there's the, you know, the calm in the center of the hurricane or whatever, you know, this actually will end too, you know?
Yeah. Yeah, thank you, Una Rose. And I think one of the things that's really coming across even in our second webinar is just the feeling of togetherness and solidarity between, you know, all the countries, for instance, represented on this webinar, all our partners in low middle income countries, in European countries. It's really all of us together trying to work out what best to do. So thank you. I'll hand back to Hala.
Yeah. Thank you, everyone, and thank you for our speakers. They were really great, and I'm really sure that everyone also agree with me. And just now for this webinar, I will ask the audience if they can just do this very short evaluation form. This will be really helpful for us, and it will help us also into developing our future webinars. So now we will put it in the chat box, the link to the evaluation form. Can you put it, please, Ellen or Sky? Yep, so it will be there. And just to let you know that our next week we will focus, our next week webinar, we will focus on the opportunities and the challenge for health partnerships during COVID-19. If you have any questions for the speakers, please send them to in advance to our email, info@ester.eu. We will put it now also the slide on the screen now, please. Thank you. Yes, and thank you also for all the attendees for joining us today, and we hope to see you also again in our coming webinar. And also for the recording of today, it will be available in our website, www.globalhealth.ie, and also on www.ester.eu. If you miss our first webinar, it is already posted there, and also we have it in our YouTube channels. And don't forget to check our COVID-19 portal with the best and most updated information on global health. And this is on www.globalhealth.ie/coronafacts/. Thank you everyone for joining, and we hope to see you again next week. Thank you.
Thank you, everybody.
Thanks a lot.
Bye.
Thank you.
Salut.
Bye. Bye.
Bye.